always one of our goals is to save bone at the time of surgery, because as joint replacement surgeons, we're always looking to the future. And the more bone that person has or that person is able to retain, one, the better they're going to do, and two, if there's ever any issue that comes decades down the road and they ever need it revised, it always is a tremendous advantage to have more bone stock available at the time. There's no doubt, to this point, we see a dramatic difference in the amount of bone that we have to take to perform this surgery versus a standard off-the-shelf knee replacement. We even sometimes look at and compare it on the back table, what we've taken away or what we've resected from that bone, and it can be half or less sometimes than what we traditionally would have done.
In the operating room, I've noticed that I've removed a lot less bone with the Conformis implant. I've actually tracked all that data on my old implants that I was using off-the-shelf implants and then with the new custom iTotals. And I actually removed 25% less bone with the iTotal. And that's because of a number of reasons, but mostly it's because the implant is tailor-made to that patient, and so you don't have to resect extra bone just to compensate for the joint space being uneven. With an off-the-shelf implant, we end up taking a lot more bone just to try to make that cut happen.
I'm shocked at the end of the case when we gather all the amount of bone we've actually removed and compare that to the amount of bone removed with a standard knee replacement, because many times it's less than half. So I think about that being a tremendous advantage for my patient, because when that patient may need a more surgery down the road, we've preserved so much of their bone. So for the younger, more active patient who unfortunately needs a knee replacement at a younger age, we've equipped them to be able to handle more surgery, more involved surgery, and by preserving their bone stock.
We probably do see at least a 25% savings, because most of the time when we make the femoral cut, we were taking 10 millimeters off with the off-the-shelf components, and on most of these we take about 6 millimeters off. The other thing that we would do when we had a patient that had a flexion contracture, we would have to take a little bit more femoral bone off because we couldn't get the prosthesis to fit correctly given the deformity that the patient had. Well, all of those compromises I don't have to do anymore. I've still taken 6 millimeters off the end of the bone, whether the patient has a flexion contracture or not, because once I do that and once I put it back the way it's supposed to, all of their ligaments come back into balance. And so I don't have to worry about a flexion contracture anymore because the ligaments just go back to where they're supposed to. It's really difficult when I talk to orthopedic surgeons that have done a lot of total joints or that have trained in a total joint program. It's very difficult for them to grasp this concept because they're all about soft tissue balancing. And when I explain to them that this is really not a total knee per se, this is a resurfacing of your knee, we're taking a lot less bone, and what we're really doing is putting it back to where it's at its homeostatic state, where it's basically back to normal. And once you do that, it just fits perfectly, and the patients, their flexion returns, their extension returns, and their stability returns.